The term interstitial lung disease, also called diffuse interstitial lung disease, fibrotic interstitial lung disease, and pulmonary fibrosis, refers to a broad group of inflammatory lung disorders. More than 180 disease entities are characterized by acute, subacute, and chronic inflammatory infiltration of alveolar walls by the cells, fluid, and connective tissue. If left untreated, the inflammatory process can progress to irreversible pulmonary fibrosis. The interstitial lung disease group consists of a wide range of illnesses with varied causes, treatments, and prognosis. The anatomical alterations of interstitial lung disease may involve the bronchi, alveolar walls, adjacent alveolar spaces. In severe cases, the extensive inflammation leads to pulmonary fibrosis, granulomas, honeycombing, and cavitation. During the acute stage of interstitial lung disease, the general inflammatory condition is characterized by edema and infiltration of a variety of white blood cells in the alveolar walls and interstitial space. Bronchial inflammation and thickening and increasing airway secretions also may be present. Because there are more than 180 different pulmonary disorders classified as interstitial lung disease, it is helpful to group them accordingly to their occupational or environmental exposure, disease association, and specific pathology. Exposure to asbestos may cause asbestosis, a common form of interstitial lung disease. Asbestos fibers are a mixture of fibrous minerals composed of hydrosilicates of magnesium, sodium, and iron in various proportions. There are two primary types, amorphoids and chrysotiles. Asbestos fibers typically range from 50 to 100 microns in length and are about a half a micron in diameter. Chrysotiles have the longest and strongest fibers. Asbestos fibers can be seen by microscope within the thickened septa as brown or orange baton-like structures. The fibers characteristically stain for iron with Perl stain. The pathological process may affect only one lung, a lobe, or a segment of the lobe, although multi-lobe involvement is the most common. The lower lobes are most commonly affected. Pleural calcification is common and diagnostic in patients with asbestos exposure history. Common sources associated with asbestos fibers include acoustic products, automotive undercoating, brake lining, cements, clutch casings, floor tiles, firefighting suits, fireproof paints, insulation, roofing materials, ropes, and steam pipe material. Coal dust. The pulmonary deposition and accumulation of large amounts of coal dust cause coal workers' pneumoconiosis. Coal workers' pneumoconiosis is also known as coal miner lung and black lung. Miners who use cutting machines at the coal face have the greatest exposure, but even relatively minor exposure may result in the disease. Indeed, cases have been reported in which coal miners' wives developed the disease, presumably from shaking out the dust from their husband's work clothes. Simple coal workers' pneumoconiosis is characterized by the presence of pinpoint nodules called coal macules or black spots throughout the lung. Coal macules often develop around the first and second generation respiratory bronchioles and cause the adjacent alveoli to retract. This is called foci emphysema. Complicated coal workers' pneumoconiosis or progressive massive fibrosis is characterized by areas of fibrotic nodules greater than 1 centimeter in diameter. The fibrotic nodules generally appear in the peripheral regions of the upper lobes and extend toward the hilum with growth. Nodules are composed of dense collagenous tissue with black pigmentation. Coal dust by itself is chemically inert. The fibrotic changes in coal workers' pneumoconiosis are usually caused by silica. Silica. Silicosis, also called quartz silicosis or grinder disease, is caused by the chronic inhalation of crystalline, free silica, or silicon dioxide particles. Silica is the main component of more than 95% of the rocks of the earth. It is found in sandstone, quartz, flint, granite, many hard rocks, and some clays. Beach sand is mostly quartz. Simple silicosis is characterized by small rounded nodules scattered throughout the lungs. No single nodule is greater than 9 millimeters in diameter. Patients with simple silicosis are usually symptom-free. Complicated silicosis is characterized by nodules that coalesce and form large masses of fibrous tissue, usually in the upper lobes and the peripheral hilary regions. In severe cases, the fibrotic regions may undergo tissue necrosis and cavitate. The following are common occupations associated with silica exposure: tunneling, hard rock mining, sand blasting, quarrying, stone cutting, foundry work, ceramics work, abrasive work, brick making, paint making, polishing, stone drilling, and well drilling. Beryllium. Beryllium is a steel gray, lightweight metal found in certain plastics and ceramics, rocket fuels, and X-ray tubes. As a raw ore, beryllium is not hazardous. When it is processed into a pure metal or one of its salts, however, it may cause a tissue reaction when inhaled into the lungs or implanted into the skin. Acute inhalation of beryllium fumes or particles may cause a toxic or allergic pneumonitis, sometimes accompanied by rhinitis, pharyngitis, and tracheobronchitis. More complex form of berylliosis is characterized by the development of granulomas and diffuse interstitial inflammation reaction. Organic materials exposure. Hypersensitivity pneumonitis, also called allergic alveolitis or extrinsic allergic alveolitis, is a cell-mediated immune response of the lungs caused by inhalation of a variety of offending agents or antigens. Such antigens include grains, silage, bird droppings or feathers, wood dust, especially redwood and maple, cork dust, animal pelts, coffee beans, fish meal, mushroom composite, and molds that grow on sugarcane, barley, and straw. The immune response to these allergens results in the production of antibodies and an inflammatory response. The lung inflammation or pneumonitis develops after repeated and prolonged exposure to the allergen. The term hypersensitivity pneumonitis or allergic alveolitis is often renamed according to the type of exposure that caused the lung disorder. For example, the hypersensitivity pneumonitis caused by inhalation of moldy hay is called farmer's lung. Radiation therapy in the management of cancer may cause interstitial lung disease. Radiation-induced lung disease is commonly divided into two major phases: the acute pneumatic phase and a late fibrotic phase. Acute pneumonitis is rarely seen in patients who receive a total radiation dose of less than 3,500 rads. By contrast, doses in excess of 6,000 rads over 6 weeks almost always cause interstitial lung disease in and near the radiated areas.
The acute pneumonic phase develops about 2 to 3 months after exposure. Chronic radiation fibrosis is seen in all patients who develop acute pneumonitis. The late phase of fibrosis may develop 1. Immediately after the development of an acute pneumonitis, 2. Without any acute pneumotic period, or 3. After a symptom-free latent period. When fibrosis does develop, it generally does so 6 to 12 months after radiation exposure. Pleural effusion is often associated with late fibrotic phase. The precise cause of radiation-induced lung disease is not known. The establishment of diagnosis is similar to that for drug-induced interstitial disease, for example, by obtaining a history of recent radiation therapy and confirming the diagnosis with an open lung biopsy. Irritant gases. The inhalation of irritant gases may cause acute chemical pneumonitis and, in severe cases, interstitial lung disease. Most exposures occur in the industrial setting. For example, common irritant gases associated with interstitial lung disease, such as chlorine, is found in chemical and plastic industries or water disinfection. Ammonia is found in commercial refrigeration, smelting of sulfide ores. Ozone is found in welding. Nitrogen dioxide may be liberated after exposure of nitric acid to air. And phosphagen is used in the production of aniline dyes.
Systemic diseases. Connective tissue collagen vascular disease. Scleroderma. Scleroderma is characterized by chronic hardening and thickening of the skin caused by new collagen formation. It may occur in a localized form or as a systemic disorder called systemic sclerosis. Progressive systemic sclerosis is a relatively rare autoimmune disorder that affects the blood vessels and connective tissue. It causes fibrous degeneration of the connective tissue of the skin, lungs, and internal organs, especially the esophagus, digestive tract, and kidney. Scleroderma of the lung appears in the form of interstitial lung disease and fibrosis. Of all the collagen vascular disorders, scleroderma is one in which the pulmonary involvement is most severe and most likely to cause significant scarring of the lung parenchyma. The pulmonary complications include diffuse interstitial fibrosis, severe pulmonary hypertension, pleural disease, and aspiration pneumonitis, secondary to esophageal involvement. Scleroderma also may involve the small pulmonary vessels and appears to be independent of the fibrotic process involving the alveolar walls. The disease is most commonly seen in women 30 to 50 years of age. Rheumatoid arthritis. Rheumatoid arthritis is primarily an inflammatory joint disease. It may, however, involve the lungs in the form of pleurisy with or without effusion, interstitial pneumonitis, necrobiotic nodules with or without cavities, Kaplan syndrome, and pulmonary hypertension secondary to pulmonary vasculitis. Pleurisy with or without effusion is the most common pulmonary complication associated with rheumatoid arthritis. When present, the effusion is generally unilateral, often on the right side. Men appear to develop rheumatoid pleural complications more often than women. Rheumatoid interstitial pneumonitis is characterized by alveolar wall fibrosis, interstitial and interalveolar mononuclear cell infiltration, and lymphoid nodules. In severe cases, extensive fibrosing, alveolitis, and honeycombing may develop. Rheumatoid interstitial pneumonitis is also more common in male patients. Necrobiotic nodules are characterized by the gradual degeneration and swelling of lung tissue. The pulmonary nodules generally appear as well-circumscribed masses that often progress to cavitation. The nodules usually develop in the periphery of the lungs and are more common in men. Histologically, the pulmonary nodules are identical to the subcutaneous nodules that develop in rheumatoid arthritis. Kaplan syndrome, also called rheumatoid pneumoconiosis, is a progressive pulmonary fibrosis of the lung commonly seen in coal miners. Kaplan syndrome is characterized by rounded densities in the lung periphery that often undergoing cavity formation and in some cases calcification. Pulmonary hypertension is a common secondary complication caused by progression of the fibrosis alveolitis and pulmonary vasculitis. Sjögren's syndrome is a lymphocytic infiltration that primarily involves the salivary and lacrimal glands and manifests by dry mucous membranes, usually in the mouth and eyes. Pulmonary involvement frequently occurs in Sjögren's syndrome and includes pleurisy with or without effusion, interstitial fibrosis that is indistinguishable from that of other collagen vascular disorders, and infiltration of lymphocytes of the tracheobronchial mucous glands, which in turn causes atrophy of the mucous glands, mucus plugging, atelectasis, and secondary infections. Sjögren's syndrome occurs most often in women 90% of the time and is commonly associated with rheumatoid arthritis. 50% of the patients with Sjögren's syndrome have rheumatoid arthritis. Polymyositis and dermatomyositis. Polymyositis is a diffuse inflammatory disorder of the striated muscles that primarily weakens the limbs, neck, and pharynx. Dermatomyositis is a term used when erythematosus, skin rash, accompanies the muscle weakness. Pulmonary involvement develops in response to recurrent episodes of aspiration pneumonia caused by esophageal weakness and atrophy. Hypostatic pneumonia secondary to weakened diaphragm and drug-induced interstitial pneumonitis. Polymyositis, dermatomyositis, is seen more often in women than men at about a 2-to-1 ratio. The disease occurs primarily in 2 age groups, before the age of 10 years and from 40 to 50 years of age. In about 40% of the patients, the pulmonary manifestations are seen 1 to 24 months before the striated muscles or skin shows signs and symptoms. Systemic lupus erythematosus is a multi-system disorder that mainly involves the joints and skin. It also may cause serious problems in numerous other organs, including the kidneys, lungs, nervous system, and heart. Involvement of the lungs appears in about 50% to 70% of the cases. Pulmonary manifestations are characterized by pleurisy, with or without effusion, atelectasis, diffuse infiltrates and pneumonitis, diffuse interstitial lung disease, uremic pulmonary edema, diaphragmatic dysfunction, and infections. Pleurisy with or without effusion is the most common pulmonary complication of systemic lupus erythematosus. The effusions are usually exudates with high protein concentration and are frequently bilateral. Atelectasis commonly develops in response to the pleurisy, effusion, and diaphragmatic elevation associated with systemic lupus erythematosus. Diffuse non-infectious pulmonary infiltrates and pneumonitis are common. In severe cases, chronic interstitial pneumonitis may develop. Because systemic lupus erythematosus frequently impairs the renal system, uremic pulmonary edema may occur. Systemic lupus erythematosus also has been found to be associated with diaphragmatic dysfunction and reduced lung volumes. Some research suggests that diffuse myopathy affecting the diaphragm is the source of this problem. About 50% of the cases have complicating pulmonary infection. Sarcoidosis is a relatively common chronic disorder of unknown origin characterized by the formation of tubercles of non-necrotizing epithelioid tissue, non-caseating granulomas. Common sites are the eyes, lungs, spleen, liver, skin, mucous membranes, and lacrimal and salivary glands, usually with involvement of the lymph glands. The lung is the most frequent affected organ, with manifestations generally including interstitial lung disease, enlargement of the mediastinal lymph nodes, or a combination of both. On the clinical laboratory hallmarks of the sarcoidosis is an increase in all three major immunoglobulins, M, G, and A. Also common is an elevation of the angiotensin converting enzyme. The disease is more common among African Americans and appears more frequently in patients 10 to 40 years of age, with the highest incidence at age 20 to 30 years. Women are affected more often than men, especially among African Americans. Idiopathic pulmonary fibrosis is a progressive inflammatory disease with varying degrees of fibrosis and in severe cases honeycombing. The precise cause is unknown. Although idiopathic pulmonary fibrosis is the term most frequently used in this disorder, numerous other names appear in the literature, such as acute interstitial fibrosis of the lung, cryptogenic fibrosing alveolitis, Hammond-Rich syndrome, honeycombing lung, interstitial fibrosis, and interstitial pneumonitis. Idiopathic pulmonary fibrosis is commonly separated into the following two major disease entities according to its predominant histological appearance: desquamative interstitial pneumonia and usual interstitial pneumonia. In desquamative interstitial pneumonia, the most prominent features are hyperplasia and desquamation of the alveolar type II cells. The alveolar space are packed with macrophages, and there is even distribution in the interstitial mononuclear infiltrate. In usual interstitial pneumonia, the most prominent features are interstitial and alveolar wall thickening caused by chronic inflammatory cells and fibrosing. In severe cases, fibrotic connective tissue replaces the alveolar walls. The alveolar architecture becomes distorted, and eventually honeycombing develops. When honeycombing is present, the inflammatory infiltrate is significantly reduced. The prognosis for patients with desquamative interstitial pneumonia is significantly better than that for the patients with usual interstitial pneumonia. Some experts think desquamative interstitial pneumonia and usual interstitial pneumonia are two distinct interstitial lung disease entities. Others, however, think desquamative interstitial pneumonia and usual interstitial pneumonia are different stages of the same disease process. Idiopathic pulmonary fibrosis is most commonly seen in men 40 to 70 years of age. Diagnosis is generally confirmed by open lung biopsy. Most patients diagnosed with idiopathic pulmonary fibrosis have more chronic progressive course, and death usually occurs in 4 to 10 years. Death usually is the result of progressive acute ventilatory failure complicated by pulmonary infection. Idiopathic pulmonary fibrosis is a progressive inflammatory disease with varying degrees of fibrosis and in severe cases honeycombing. The precise cause is unknown. Although idiopathic pulmonary fibrosis is the term most frequently used in this disorder, numerous other names appear in the literature, such as acute interstitial fibrosis of the lung,
cryptogenic fibrosing alveolitis, Hammond-Rich syndrome, honeycombing lung, interstitial fibrosis, and interstitial pneumonitis. Idiopathic pulmonary fibrosis is commonly separated into the following two major disease entities according to its predominant histological appearance: desquamative interstitial pneumonia and usual interstitial pneumonia. In desquamative interstitial pneumonia, the most prominent features are hyperplasia and desquamation of the alveolar type II cells. The alveolar space are packed with macrophages, and there is even distribution in the interstitial mononuclear infiltrate. In usual interstitial pneumonia, the most prominent features are interstitial and alveolar wall thickening caused by chronic inflammatory cells and fibrosing. In severe cases, fibrotic connective tissue replaces the alveolar walls. The alveolar architecture becomes distorted, and eventually honeycombing develops. When honeycombing is present, the inflammatory infiltrate is significantly reduced. The prognosis for patients with desquamative interstitial pneumonia is significantly better than that for
Cryptogenic organizing pneumonia, also known as bronchiolitis obliterans organizing pneumonia, BOOP, is characterized by connective tissue plugs in the small airways, hence the term bronchiolitis obliterans, and mononuclear cell infiltration of the surrounding parenchyma, hence the term organizing pneumonia. Although most cases have no identifiable cause and therefore are considered idiopathic, cryptogenic organizing pneumonia has been associated with various connective tissue diseases, toxic gas inhalation, and infection. The chest radiograph commonly shows patchy infiltrates of alveolar rather than interstitial involvement. Diagnosis may require a surgical biopsy when the clinical radiographic data are uncertain. Cryptogenic organizing pneumonia is one of the interstitial lung diseases in which both restrictive and obstructive pathophysiologic findings are present.
Lymphoangioleiomyomatosis is a rare lung disease involving the smooth muscles of the airways and affects women of childbearing age. It is characterized by the proliferation of disorderly smooth muscle proliferation throughout the bronchioles, alveolar septa, and perivascular space and lymphatics. Lymphoangioleiomyomatosis causes the obstruction of small airways and lymphatics. Common clinical features associated with lymphoangioleiomyomatosis are recurrent pneumothorax and cryothorax. The diagnosis is confirmed with an open lung biopsy. The prognosis is poor. The disease slowly progresses over 2 to 10 years, ending in death resulting from ventilatory failure. Pulmonary Langerhans cell histiocytosis is a smoking-related interstitial lung disease characterized by mid-lung zone star-shaped nodules with adjacent thin-walled cysts. It was once considered a benign condition in adults, but long-term complications such as pulmonary hypertension are becoming increasingly recognized. Diagnosis is confirmed histologically by tissue biopsy. Pulmonary alveolar proteinosis is a condition of unknown cause in which alveoli become filled with protein and lipids. The lipid-protein material is similar to the pulmonary surfactant produced by type II cells. In addition, the alveolar macrophages are generally dysfunctional in this disorder. The disease is most commonly seen in adults 20 to 50 years of age. Men are affected twice as often as women. The chest radiograph typically reveals bilateral infiltrates that are most prominent in the perihilar regions, which is like a butterfly pattern. It has often indistinguishable from pulmonary edema. Air bronchograms are commonly seen. The diagnosis is confirmed by transbronchial or open lung biopsy or by analysis of fluid removed during a bronchial alveolar lavage. The pulmonary vasculitides consist of a heterogeneous group of pulmonary disorders characterized by inflammation and destruction of the pulmonary vessels. The major disorders in this category include Wegener's granulomatosis, Chirac-Strauss syndrome, and lymphomatoid granulomatosis. Wegener's granulomatosis is a multisystem disorder characterized by a necrotizing granulomatosis vasculitis, focal segmental glomerulonephritis, and variable degrees of systemic vasculitis of the small veins and arteries. In the lungs, numerous 1 to 9 centimeter diameter nodules are commonly seen in the upper lobes, and cavity formation is often associated with larger lesions. Wegener's granulomatosis is considered an aggressive and fatal disorder, although the prognosis has significantly improved with the use of cytotoxic agents. This disorder is most commonly seen in men older than 50 years of age. Diagnosis is confirmed by open lung biopsy. Histological examination reveals lesions with marked central necrosis of the pulmonary parenchyma. The area surrounding the necrotizing lesion contains numerous inflammatory white blood cells with fibroblasts. Inflammatory cell infiltrate and necrotizing vasculitis are seen in the adjacent blood vessels. Chirac-Strauss syndrome is a necrotizing vasculitis that predominantly involves the small vessels of the lungs. Granulomatosis lesions are characterized by heavy infiltrate of eosinophils, central necrosis, and peripheral eosinophilia. Cavity formation is rare in this disorder. Clinically, symptoms of asthma usually precede the onset of vasculitis. In recent years, a rapid tapering of oral steroids with substitution of leukotriene inhibitors, such as Singulair or Acrylate, have been associated with deaths from fulfillment of Chirac-Strauss syndrome reactions. Neurologic disorders, such as mononeuritis multiplex, a simultaneous disease of several peripheral nerves, are frequently associated with this disorder. Diagnosis is usually confirmed with an open lung biopsy, and the disease is often rapidly fatal. Miscellaneous diffuse interstitial lung diseases. Goodpasture syndrome. Goodpasture syndrome is a disease of unknown cause that involves two organ systems, the lungs and the kidneys. In the lungs, there are recurrent episodes of pulmonary hemorrhage and hemoptysis, and in some cases pulmonary fibrosis, presumably as a consequence of episodes of pulmonary bleeding. In the kidney, there is glomerular nephritis, characterized by the infiltration of antibodies within the glomerular basement membrane. These circulating antibodies function against the patient's own GBM. They are commonly abbreviated as anti-GBM antibodies. It is thought that the anti-GBM antibodies cross-react with the basement membrane of the alveolar wall, and their deposition in the kidneys and in the lungs is responsible for producing the pathophysiologic process of the disease. Goodpasture syndrome is usually seen in young adults. With the appropriate treatment, the 5-year survival rate is almost 80%. An interesting feature of Goodpasture syndrome is that patients frequently demonstrate an increased pulmonary diffusion capacity, the DLCO, which is direct contrast to most interstitial lung disorders. The increased carbon monoxide uptake commonly seen in this disorder is thought to be caused by the increased amount of retained hemoglobin in the pulmonary tissue. Chronic eosinophilic pneumonia is characterized by infiltration of eosinophils and, to a lesser extent, macrophages in the alveolar and interstitial spaces. Clinically, a unique feature of this disorder is often seen on the chest radiograph, consisting of peripheral distribution of pulmonary infiltrates. This radiographic pattern is commonly referred to as a photographic negative of pulmonary edema. This is because of the dense peripheral infiltration with sparing of the perihilar areas seen in chronic eosinophilic pneumonia, compared with central pulmonary infiltration with sparing of the lung periphery seen in pulmonary edema. An increased number of eosinophils is also commonly seen in the peripheral blood. Histological diagnosis is made by means of an open lung biopsy. Idiopathic pulmonary hemocystiosis is an entity of unknown cause that is characterized by recurrent episodes of pulmonary hemorrhage similar to that seen in Goodpasture syndrome. Histologic examination reveals that alveolar hemorrhage with hemoceridiin-laden macrophages and hyperplasia of the alveolar epithelium. Unlike in Goodpasture syndrome, however, there is no evidence of circulating anti-GBM antibodies attacking the alveoli, or GBMs, and in this disorder is not associated with renal disease. Idiopathic pulmonary hemocystiosis is most often seen in children. As in Goodpasture syndrome, patients commonly demonstrate an increase in their DLCO, which is in direct contrast to most interstitial lung disorders. Again, the increased uptake of carbon monoxide is thought to be caused by an increased amount of hemoglobin retained in the lungs. Overview of cardiopulmonary clinical manifestations associated with interstitial lung disease. The following clinical manifestations result from a pathophysiologic mechanism caused or activated by an increase in alveolar capillary membrane thickness and excessive bronchial secretions. Clinical data obtained at the patient's bedside on physical examination, vital signs, will show an increase in respiratory rate. There are several pathophysiologic mechanisms operating simultaneously may lead to this increase in ventilatory rate. Stimulation of peripheral chemoreceptors from hypoxemia. Relationship of decreased lung compliance to increased ventilatory rate. Stimulation of the J receptors. Pain and anxiety. We will also notice an increase in heart rate and blood pressure. Other physical findings that will be noted be presence of cyanosis, digital clubbing, and peripheral edema and venous distension. Because polycythemia and cor pulmonale are also associated with chronic interstitial lung disease, the following may be seen: distended neck veins, pitting edema, and enlarged and tender liver. Also will be noted on physical examination would be a non-productive cough. On chest assessment, we will note increased tactile or vocal firmness, dull percussion note, bronchial breath sounds may be present, crackles may be present, pleural fiction rub may be noted, and whispered pectocolloquy may be noted. Decreased diffusing capacity. There is an exception to the expected decreased diffusion capacity in the two interstitial lung diseases, Goodpasture syndrome and idiopathic pulmonary hemosiderosis. The DLCO is often elevated in response to the increased amount of hemoglobin retained in the alveolar space that is associated with these two disorders. Abnormal laboratory tests will show an increase in hematocrit and hemoglobin, which is polycythemia, secondary to chronic hypoxemia. Radiographic findings. Radiological findings vary according to the cause. The typical findings will show bilateral reticular nodule pattern, irregular shape opacities, granulomas, cavity formation, honeycombing, pleural effusion, and pleural thickening. General management of interstitial lung disease. The management of interstitial lung disorders is directed at the inflammation associated with the various disorders. Corticosteroids. In general, corticosteroids are commonly administered in this group of illnesses with reasonable good results, but the benefit varies remarkably from one patient and condition to another. Immunosuppressive agents. Like steroids, these agents are helpful in many interstitial lung diseases, though effective side effects are common. Respiratory care treatment protocols. Oxygen therapy is used to treat hypoxemia, decrease the work of breathing, and decrease myocardial work. Because of the hypoxemia associated with interstitial lung disease, supplemental oxygen is often required. The hypoxemia that develops in an interstitial lung disorder is most commonly caused by alveolar thickening, fibrosis, and capillary shunting associated with the disorder. Mechanical ventilation may be needed to provide and support alveolar gas exchange and eventually return the patient to spontaneous breathing. Because acute ventilatory failure superimposed on chronic ventilatory failure is often seen in patients with severe interstitial lung disease, continuous mechanical ventilation may be required. Continuous mechanical ventilation is justified when the acute ventilatory failure is thought to be reversible. Other treatment. Plasmapheresis. The treatment for Goodpasture syndrome is directed at reducing the circulating anti-GBM antibodies that attack the patient's GBM. Plasmapheresis, which directly removes the anti-GBM antibodies from the circulation, has been on some benefit. Bronchoalveolar lavage. Bronchial lavage is a technique involving therapeutic bronchoscopy, wherein the lungs of the patient and the pulmonary alveolar proteinosis are irrigated with a neutral solution. The solution effectively washes out the protein-containing material which is discarded. This procedure may be needed to be repeated several times to achieve the desired results.